Okay, so now we're going to talk about the pharmacology for our patient Miriam Khan. There's a few background learning objectives that you should be aware about. Narrow spectrum versus broad spectrum and bactericidal versus bacteriostatic. We'll actually define these in the lecture, and they're also more detailed in the course notes. Okay, so for the session learning objectives, obviously we need to talk about a few antibiotics which are pertinent to the treatment of this particular patient. And as you go through these exercises, you will actually discover what the diagnosis is. I'm not going to actually tell you what we're treating. You'll figure that out as the case unravels. And so the drugs that we need to learn about include ampicillin, penicillin G, gentamicin, and trimethoprim sulfamethoxazole. And so we need to know how they work, the mechanism of action, as well as the side effects, the main side effects that are associated with these drugs. Okay, so here's the drug list. Understand that if you go through the treatment guidelines, there are two alternatives listed, imatinib and linezolid. If you look in the literature, you will see that there's certain criteria as to when you progress down this list. But for today, we're really just going to focus on the frontline therapies. We're going to talk about ampicillin, gentamicin, and trimethoprim sulfamethoxazole. Okay, so let's start with ampicillin. So ampicillin is a penicillin molecule. It's a second generation semi-synthetic penicillin. Okay, and so this is obviously laboratory derived, and so they take the original penicillin molecule and they add methyl groups and so forth, and they basically change the chemical structure. We don't really teach structure-activity relationships in medical school. I used to teach that in pharmacy school, but you do need to understand that this particular structure right here in the corner is a beta-lactam. So beta-lactams are, if you remember from organic chemistry, cyclic amides, and that's what a cyclic amide looks like. This chemical structure is common in all penicillins, as well as a few other drugs that you'll learn about later in the curriculum, cephalosporins and a few others. Okay, so, excuse me, ampicillin has a broad spectrum of activity. Sorry, as I was saying, ampicillin has a broad spectrum of activity, so it covers lots of different bugs. It can go after gram-positive, gram-negative infections. It can also be used to treat both aerobic and anaerobic infections. It's available in both oral tablet form as well as IV or IM injections. And so how does it work? So mechanistically, we define it as a drug that binds to and it activates what's called the penicillin binding proteins. If you look in the immunology or the microbiology literature, sometimes they're referred to as transpeptidases. It's the same thing. Penicillin binding proteins, or PBPs, are transpeptidases. And so the way this works is basically 4 steps. The beta-lactam portion of the penicillin binds to the penicillin binding protein. Okay, that's how it got its name. And it forms this lattice or chain link type structure. And essentially, if that molecule from the antibiotic is bound to this penicillin binding protein, basically due to steric hindrance, this chain link structure, this lattice structure, basically becomes unstable. And so that really kind of manifests itself when the bacteria tries to grow and divide and proliferate. And because of the unstable structure of the cell wall, essentially the bacteria dies. And then you see the angel of death coming to kill the bacteria. And so this is basically a stepwise schema of how all penicillins work, especially ampicillin. And this is basically how these particular drugs are bactericidal. All right. So aside from this particular infection, which you will soon tell us what it is, ampicillin can be used for such things as sepsis, meningitis, respiratory tract infections, as well as both GI and GU infections. It's got some off-label uses that are listed here, and so these have been used in the past successfully in the clinic, and there are case reports that have been published, PubMed and in other literatures, but they're not officially FDA approved. Okay. Penicillin G is another penicillin. It's actually the oldest. It's the natural one that was first discovered. It has pretty good activity against several different organisms, both gram-positive and gram-negative, as it's listed here. However, it demonstrates relatively little activity against a specific subtype of bacteria, the gram-negative rods. Right? And so because it is one of the oldest penicillins out there, bacteria have produced a method, so to speak, in terms of basically to inactivate this particular drug. And so remember, the beta-lactam ring structure basically is the binding portion of the molecule that's most biologically active. What some bacteria have done is they've produced an enzyme called beta-lactamase. Okay, and this is an enzyme that basically inactivates the beta-lactam ring structure or changes its chemical activity. And so if you change the chemical activity, you change the binding. And so then basically the bacteria render the penicillin molecule inactive. All right. We found clinically that the IV administration is much more preferable to the intramuscular or IM administration, and that's due to a variety of factors, mostly centered around pharmacokinetics. Other uses for penicillin G are listed here, including syphilis, as well as syphilis during pregnancy. And then in terms of the newborn, we're looking at the treatment of group B strep or GBS in the newborn patient. The side effects for penicillin are legendary. Everybody who's taken penicillin is familiar with diarrhea, and this is really more prevalent when this particular drug is given orally. Most of the oral doses are 2 to 3 times per day, and the way in which we can kind of reduce the incidence or the side effect of diarrhea is to tell the patient or counsel the patient to take this particular drug with their meals. It doesn't alleviate entirely diarrhea, but it will dramatically reduce it. Of course, to that end, one of the major side effects with penicillins is Clostridium difficile infections. And so this is an opportunistic type of infection that has its environmental niche basically altered. And so there's, of course, in the gut, there's good bacteria, there's bad bacteria. Well, when you give something like a systemic broad spectrum antibiotic, like a penicillin, such as ampicillin or penicillin G, you basically kill the good bacteria too. And so now this basically reduces the environmental pressures that used to control the C. diff, at least locally, and now basically they've got a new environment that they can kind of grow and proliferate because their competitors have been removed. And so the other thing to consider with penicillin side effects is the presentation of a rash, and this rash is actually twofold. There's one form of the rash that resembles measles. And this usually occurs when there's a co-infection with a virus, most often mono. Okay. There's a more severe form of the rash that's associated with a hypersensitivity reaction, a type 1 hypersensitivity reaction. And that rash is also seen with bronchoconstriction and extreme itching. Okay. Penicillin is excreted primarily through the kidneys. Okay. And so this is important to remember. So patients that have reduced renal function, as evidenced by low creatinine clearance, are going to need smaller doses of penicillin than a regular patient. And in fact, they'll need 1/4 to 1/3 of the normal dose. So this is a dramatic reduction in dose. If you fail to reduce the patient, these patients are going to be the ones that are going to experience the adverse effects and the toxicity of these molecules much more frequently. And so it's really important to make sure that in the patients that have renal compromise to dramatically reduce that dose of penicillin. We're going to stop here and we're going to take a break, and then we're going to continue with the other drugs that are used to treat this patient.